Okay. At the outset, I thank Diabetes India for giving me this opportunity to be with you all. And mouth is very closely related to diabetologists because we have to tell them not only to keep their mouth clean, but they have to control whatever they are eating. So mouth plays an important role in diabetes control because unless they control their mouth and diet, we can't control diabetes. So mouth is very important. Madam already explained what are the problems with that. And my topic is there sufficient evidence to support the use of salivary biomarkers for diabetes monitoring? So if you want to monitor diabetes, we can use saliva. So you should go to your biochemistry. What are AGE, advanced glycation end products? Advanced glycation end products are proteins or lipids that become glycated as a result of exposure to sugar. So you are measuring a protein which was added by glucose, or glucose is added to them. That is HbA1c. What we do, they are a biomarker implicating in aging and the development of or worsening of many degenerative diseases such as diabetes, atherosclerosis, chronic kidney disease. So in chemistry, an adduct is a product of a direct addition of two or more distinct molecules. So here glucose is added to proteins that we were measuring, and glycosylation is the reaction in which a carbohydrate, that is a glycose donor, is attached to hydroxyl other functional group, another molecule, in order to form a glycoconjugate. So this is what we measure routinely to know. So the glycation or glycosylation will cause the indirect measurement of glucose. So this is how they do that. SMBG is self-monitoring a blood glucose one day, and glycated albumin, where glucose is deposited on the albumin, we measure that, and HbA1c you know. So this is how we measure, and what they say is increased glycosylation correlates with hyperglycemia. So if you can measure your glycation or glycosylation products, it can show you indirectly how your diabetes is controlled. So this is an article, salivary protein glycosylation as a non-invasive biomarker for assessment of glycemia. So we can assess the glycemic control with saliva. So this was a study done by our senior diabetologist, Professor P. Rao, and they found out that this is how they do it. They take a swab and put it in the mouth, and they change it into syringe and they squeeze the saliva, and that saliva is measured. So salivary protein glycosylation levels were measured using the method developed to preferentially detect sialic acid and fructose, as these are major monosaccharides found in secreted glycoproteins, and our preliminary studies demonstrated that saliva reactivity to sialic acid and fucose binding lactins was correlated, and both are associated with hyperglycemia. So what they say is, in this study, salivary glycosylation measures correlated with the level of glycemic control in type 1 and type 2 diabetics. The degree of variation across time in participants with poor glycemic control indicates that salivary glycosylation measures are more sensitive to short-term changes in glycemia than HbA1c or fructosamine. Salivary glycosylation represents an alternative non-invasive method for monitoring of glycemia. Till now, all these methods are not FDA approved. There are methods we can measure direct glucose also, but it is also not FDA approved. So, so what they do is, I told you already, salivary glycosylation, it represents 1 to 2 weeks of blood glucose control, and point of care technology, chemistry to measure salivary protein glycosylation. There are methods available. I came to know it's not yet approved. The glycheck test uses specific chemistry to detect the carbohydrate component of salivary glycoproteins. Diabetomix, they developed this. So easy to use non-invasive test, 2 to 5 minutes to read from the drop of saliva, and test once 7 to 14 days, because we are measuring 7 to 14 days blood sugar, and provides a quick estimated average glucose values to monitor treatment. So these are the advantages: painless, point of care, protein based, pathobiologic, short term diabetes control can be measured with this. So these are all the differences how this glycosylation versus glycation. So what I want to tell you is non-glycosylated protein looks like that. When sugar is added, then it becomes glycosylated protein. And normal, how this low glycosylation, it is normal. If there is disease like diabetes, there will be increased glycosylation. And if you treat them properly, you will have reduced glycosylation. So these are the salivary protein glycosylation as a non-invasive biomarker for assessment of glycemia. They came to a conclusion that salivary glycosylation assessment correlated with weekly levels of glycemic control. The degree of variation across time in participants with poor glycemic control indicates that salivary glycosylation measures are more sensitive to short-term changes in glycemia. Salivary glycosylation represents an alternative, non-invasive method for short-term monitoring of glycemia. So this is how they do this. I told you already. So glucemia. This is the glucemia uses specific chemistry to detect sugars on salivary glycoproteins. I explained already how it is normal disease and treated. So this is the instruments. They are not at FDA approved. They are doing research. I called P. Roger and he says that it's not yet approved and they're trying. And it's a future because most of the patients, they don't like to give their blood. But if you can use saliva, that's very useful. So we are waiting for these tests to be FDA approved and better, have better what you call evidence based. Then we can use these things. Till then, we have to go that normal way. And I hope my patient, if I come, my patient comes, take a swab and test. That will be very useful to them. SMBG and now CGMS, they are useful. They are non-invasive. So they compared this with that and they found out it's good. Okay. Thank you very much. And what I want to tell you is, so these I searched for the whether they can measure glucose directly from the saliva. There are some problems with that, and FDA is not yet approved these instruments. If we can get, that will be very good. Now I want to tell you about smiling because I promote smiling. And so Dr. Smile Club, we started that, and Smile Diabetes Research Trust we have. So if you smile, smiling makes us more attractive. Smiling exudes positivity. If a person smiles, it's positivity. And smiling is infectious. Smiling reduces stress. Smile brighten another person's day. Smiling can lift our faces and makes us look younger. I tell my female patients smile, so you no need for makeup or lipstick. Smiling is a natural drug, and smiling denotes forgiveness and openness to forgive. And smiling allows us to appear self-confident. They say that if you're smiling, you and smiling brings us close to our friends and family. Usually, people who are smiling, they are liked more. So we started this Smile Day. We are celebrating and we conducted this program, How to Improve Smile in Diabetics, including our IDF president. All are involved. So we want to promote smiling in our day-to-day practice because smiling can make things better. Particularly if a patient comes and if you smile, it will be very useful because when we are very much burdened with our routine practice, and we will be very serious. But if you start smiling to your patient, it will improve a lot. So research has shown that laughter yoga has many benefits where they laugh voluntarily to get more benefits. But I don't advise that. But at least smile with your patients. Spend more time to laugh with your patients. I mean to say, smile and be friendly, be courteous. I believe that patients need the most smile in their life. So they waited for so long, 3 hours. Some people maybe morning till evening they are waiting. And when they come inside, you should give a smile and give them something positive message. Keep smiling and let us smile together. Let us laugh together for 30 seconds. Are you ready? Okay. Very good. So take more time to laugh. Thank you very much. So Thank you so much. Your presentation brought smile to my face. I don't know about people. This is very presentation. Okay, so
Thank you very much, Raman sir. Actually, we are smile makers, and we believe in healthy smiles. And dentists always say molar to molar smile. So we definitely are few of the people who are responsible to bring smiles on people's face. Thank you for this wonderful lecture. That is the subconscious response. Yes. I would like to request and welcome our next speaker, Dr. Priya Phatak. Dr. Priya Phatak has done her bachelor's in dentistry from AMC Dental College and Hospital and her master's in public health in biostats. These are her some of the publications which we can see, and she has done this from the School of Public Health and Health Policy. That's right. Yeah. CUNY School of Public Health and Health Policy. Right. And the topic that she would be covering is a debate, and she would be speaking in favor of the motion that is, should periodontal therapy be standardized as part of diabetes management plans? Over to you.
Thank you. Thank you to Team Diabetes India for giving me this amazing opportunity and making me a part of this amazing lineup of esteemed faculty that we have here today. Today, I'm glad to present my opinion on the topic whether periodontal therapy should be standardized as part of diabetes management plans. Let me start with some stats which makes it undeniable. Periodontal disease is highly prevalent in patients with diabetes. Studies have reported a prevalence of between 46 to 90%, which is nearly double the rate of periodontal disease in patients without diabetes. Multiple international health organizations have acknowledged this relationship, including the American Dental Association. Even the American Diabetes Association has recommended that patients be referred to a dentist for periodontal examination as an essential component in the Standards of Care in Diabetes 2025. If that was not evidence enough, our very own RSSDI guidelines, penned by none other than Dr. Bansi Sabu, Dr. Manoj Chavla, Dr. Sujoy Ghosh, to name a few, have also emphasized the importance of including periodontal therapy and periodontal examination in order to achieve better outcomes for our patients. So, I would just like to begin by saying that periodontal disease does not just affect your teeth or your gums. It has systemic complications involved too. In fact, periodontitis is considered to be the sixth complication of diabetes. And the bacteria that cause gum disease or periodontitis, they don't stay restricted to your gums. They enter the bloodstream and create a systemic inflammatory response. This inflammatory response can increase insulin resistance and hence hamper diabetes control in our patients. Periodontal disease has also been found to have multiple other systemic inflammatory effects, ranging from halitosis to heart disease, respiratory disease, and many more. In fact, pathogens associated with an unhealthy mouth are the same as those associated with multiple serious systemic diseases, including but not limited to Alzheimer's disease, diabetes insulin resistance, adverse pregnancy outcomes, and even cardiovascular diseases. Apart from the obvious ways in which periodontal disease can cause diabetes control, there are a few more. First, it can lead to loss of teeth and difficulty in chewing, which will compromise our patient's nutrition, and this will lead to further poor diabetes control. Loss of teeth can also trigger feelings of anxiety, stress, and low self-esteem, all of which will negatively impact a person's quality of life. And a lower quality of life will further lead to poor glycemic control. Let me answer common questions that might come to everyone's mind. First, are the two diseases really linked? Yes, there is a bidirectional relationship that has been established, and a rise in one can lead to a rise in the other. Second, does periodontal disease really affect diabetes control? Yes, periodontal disease can cause systemic inflammation and enhance insulin resistance. Third, will improvement in glycemic control alone improve the patient's periodontal condition? No. It can prevent further progression of the disease, but it will definitely not reverse the disease. And fourth, can periodontal therapy really improve glycemic control? Yes. Periodontal therapy has been shown to have a positive effect in improving glycemic control by reducing A1C levels by 0.5%. To put things into perspective, this effect is similar to what is achieved by adding a second line oral medication. Look at this picture. What is the first thing that you notice? Well, let's take a closer look. Even though this person was also missing an eyebrow, I think one of the first thing that most of us noticed was his missing tooth. This just goes on to prove how important your smile is, how important a healthy smile is. And I think Dr. Ramakrishna, I think he made a very good point about how important it is. Let's take a look at some familiar faces to prove my point. This just emphasizes how important a healthy smile is and how it can shape one's personality. Think of your body like a cricket team where all the organs are working together for us to win the game. If the batsmen and the bowlers are playing well, but if the fielders are letting balls slip by, we might end up losing the game. Similarly, if we ignore periodontitis, we might risk losing the diabetes game. Many people might argue that providing periodontal therapy for our patients would be expensive and time consuming, but let me put it this way. It is far easier, far cheaper, and far less time consuming to treat periodontal disease now than to treat the systemic and local complications that it might present if it is neglected right now. Incorporating dental and periodontal checkups and periodontal therapy can significantly reduce bacterial load and systemic inflammation and will help in preventing future complications. I believe that as we move into an era of providing personalized and holistic care to our patients, it is not just essential to provide periodontal therapy to our patients, but it is absolutely essential. Thank you.
Very well said and very good presentation, very crisp, very neat presentation and absolutely to the points.
Thank you.
So, yes, sir. Any questions here? I am in favor of this.
Well, I would be biased because I would like to hear Dr. Deepak Chudasma because she has already put the score on the scoreboard. Now he has to chase it down. So let us welcome Dr. Deepak Chudasma.
We gave so many names.
Right. Dr. Deepak.
Okay. So
Dr. Deepak is a renowned diabetologist in Junagadh and a founder of Hope Diabetes Clinic and Research Center, Junagadh. He has completed his graduation from Jamnagar Medical College and his post-graduation from A. Ramchandran Hospital, Chennai in diabetes. He is currently pursuing his PhD in Parul University and finished his clinical research course from Oxford University, UK. He has presented many national and international scientific papers in the field of diabetes and contributed as a co-author in diabetes book. Your session starts now, sir.
Thank you, Chairperson, for kind introduction. And out of box, thank you, Dr. Bansi sir, organizing committee and scientific committee for providing me this opportunity. So my role is very simple. Should a periodontal therapy or a examination in a standard as a part of diabetes care management plan? So should we make it a standardized? We'll just go through it and I'll put my perspective before immense audience. So diabetes management is a multi-nodal therapy. Like we say, diabetes education is much, diagnostic facilities should be there, individualized treatment should be there. It's not like fit one shoes to all. Prevention and management of complication by screening, by treating it, and lifestyle advice is the first priority. So whether periodontal therapy for a disease treatment should be a mandatory part of this plan. Despite the controversial connection between the periodontal disease and the diabetes, it should not be standardized as a part of diabetes management plan. Why? Why? Because there is a lack of conclusive evidence of the causal link. Why? Because some studies show that the link between the diabetes and periodontal disease, but causal relationships are not well established. Either the oral disease, which is increasing diabetes, or hyperglycemia, which has impact on the oral cavities. So some studies suggest that the periodontal therapy may marginally improve the glycemic control, but evidence are mixed up. Why the evidence are mixed up? Because in Diabetologia in 2011, one paper was there which suggests that the periodontitis and diabetes are two-way relationship. Existence of a two-way relationship between the diabetes and periodontitis, with the diabetes increase the risk of periodontitis and periodontal inflammation negatively affect the diabetes control. Some another paper in the World Diabetes Journal in 2015, they also try to establish the relation between the diabetes and periodontal infection, where effect of the periodontitis and its treatment of the diabetes metabolic control are not clearly defined, and as a result of the study remain controversial. Another study, Diabetes Care 2010, effectiveness of the periodontal treatment on a glycemic control of diabetic patient, suggests that the presence of meta-analysis periodontal treatment lead to an improvement in the glycemic control in type 2 diabetic patient for at least 3 months. So this is in support of treatment. Whereas the effect of the periodontal therapy, like in the J. Collins Periodontal Journal, it suggests that the no statistically significant difference were found in the changes of HbA1c levels between the test and the control group. No surgical periodontal therapy improved the magnitude of change in periodontal parameter as compared to the control group. So again, it's question mark, improving diabetes with periodontal treatment, it's there or not. Okay, this is like a link we have to look after, but where is the resources? Resource allocation and financial burden, another aspect of treating periodontal disease in diabetes. So diabetes patients already face high cost of medications, blood sugar monitoring, treatment of other diabetes related complications like neuropathy, retinopathy, nephropathy, or cardiovascular or cerebrovascular. Almost now 72 millions of people in India suffering from diabetes in 2023. Average total expenditure of the patient per month is almost 1300, out of which medication expenditure is almost 1000. Only 271 they will be paying to a consultation or laboratory. Only a medical aspect is 80%. You can understand that. So if I say my patient to consult a dentist for your routine dental checkup, these numbers are not matching with that. They will not go for dental checkup if I suggest them to do that as well. So again, when the resources are for the doctor consultation, like diabetologist, endocrinologist, or even MD clinician, then for the HbA1c, SMBG, or fasting PPBS, or RBS, or at least a creatinine, then the cost of the medications, and in spite of, if I'll add a dental consultation, then financial burden will be higher. So again, what are the accessibility and equality is also concerned. So universal periodontal therapy should be accessible to the health disparity. Many underserved population lack access to the dental care, and standardized therapy could further burden of these groups. Dentist unavailability in the rural area is a big concern. If we make it a plan in the standard care of treatment in type 2 diabetes, where is that availability of dentist in rural area like taluka level or beyond that? This is WHO data of India, where we can see over here Yes. So, in the policy, national health system response policies, the present third one, the presence of last one. So, recognized as a national public health program. No, it's not recognized as a national public health program. If we see over here, the availability of dental assistant or any other dental technician out of 1 lakh population, there is 0. Only a 2 dentists available in 1 lakh population. So I think we are lack of resources and availability of dentist. Patient central care. As I said, one size does not fit to all because not every diabetic patient experience severe periodontal disease and the effectiveness of the periodontal therapy may be vary. Mandating it for all the diabetic patients may lead to unnecessary treatment, adding to a healthcare cost without guaranteeing an improvement in the health outcome. So, the regular monitoring of the blood glucose level, medication adherence, and lifestyle intervention are proven to reduce the complication and improve the patient outcome. So, prioritize your fasting PPBS, HbA1c, SMBG. Then, there is a insufficient evidence to suggest that adding a standardized periodontal therapy would significantly improve the outcome in all the diabetic patients. Yes, in 2025, in standard care of diabetes, they have recommended in people with diabetes should be referred to a dental exam at least once per year, but it's not mandatory. The diabetes care guideline do not recommend mandatory periodontal care. Another aspect from the dentist point of view, if I'll see the 100 patient per week and I'll refer that 100 patient to a dentist, then number of the patient in the dentist department will be higher, burden will be there for dentist. There are requirement of dental treatment in few patients which require like severe periodontitis is there or moderate periodontitis is there. They require more time to treat it, but because of the burden of this patient, they will have a lack of time, and in that lack of time, they might miss something in whichever the required patient are treating, right? So each and every patient I cannot send to the dentist as well. Potential for overall medication like adding more standardized treatment may lead to over medication. Yes, dentists will prescribe something to them. It is the clinicians like duty to have something to their patient. The pressure to follow a rigid treatment protocol and lead a unnecessary procedure to patient who do not need them, ultimately reducing the quality of care. Periodontal therapy should remain an optional patient-driven choice. If patient has complaint, if you see something in patient, you refer to the dental. Pattern of disease and therapy for a diabetes along with the impact of generic prescribing a cost of treatment among the outpatient in tertiary care facilities where the pill burden remain high, adding more pill will improve the patient adherence? I don't think so. So, in the concluding remark, while a periodontal health is important for diabetes patient, I don't say it's not important. It's a very important. There is insufficient evidence to support the standardization of periodontal therapy within diabetes management plan. We should focus on the evidence-based, individualized care that prioritize patient's unique need, avoid unnecessary finances and treatment burden as well. Thank you so much.
Well tried, Dr. Deepak, and well played. A big round of applause for Dr. Deepak. See, when you are playing in Gujarat, so the Gujarat Titans are favorite. Okay. Any other team which plays, they are not the favorites. Having said that, the arguments which you have tried to put forth are praiseworthy. However, there are a lot of contraries to it. One of the fact that I just want to put to beyond the debate is over. Yes, we don't want to stretch because the next session also has to go. Recently in December, we had a DIOH group workshop in Delhi, chaired by Dr. Sangeeta, And one of the highlights of the workshop was that we conducted a training program for the medical practitioners on oral health program. Now, the fact is, we know and we think that we know that the oral cavity, but the fact is that many of our medical fraternity brothers and sisters are unaware to see the actual disease happening. So when I took the workshop, so when they were able to see what exactly a disease looks like, that opened the eyes. So the fact of the matter is, if we refer, the probability of detection goes higher. So as Madam said, I don't think that this is again a point of debate also. So the whole idea of diabetes oral health group is also to bring this build these bridges around that we as a dentist, we definitely are sending the patients whenever we find that the patient is diabetic to a diabetologist, but the reverse is not happening. So it is an earnest request that kindly peep into the mouth if possible. And also we have developed a tool of oral examination with a few questionnaire which we floated, and around 6 to 7 diabetic centers in India we ran the pilot in order to find out whether by the help of these few questions they are able to see and assess the oral health. And we conducted, I think, more than 1200 patients. We got the support, and it was a fantastic response. The response time was 2 minutes or less than around 2 to 3 minutes, and they were able to assess. So we are working towards it so as to build this bridge that whenever a patient who is coming to a diabetologist, please make an effort at least to send them to a dentist or a oral health practitioner. It is possible that many of the things that they will see which you have failed to see. Thank you.
So I have one more point to add. The only point that is justifying in your case is the evidence based. The evidence is not there, that's why it should not be standardized. Okay. The reason that you gave is, first of all, the cost effectiveness. So when you refer a patient for screening, so ऐसा नहीं होता कि all the patients हम start कर देते surgery करना. We just screen them and we guide them. So because dentistry is not expensive, it is. In stage पे आके if you take a missing, so अभी मैम has to नहीं sir has to if you want to take it. So that is going to work. And second point we have is lack of time. So we didn't sell the so it's just saying this. So they are you have to diabetes which then the physician's responsibility that we got the least if it is required. So thank you so much. And it was an amazing session. We had to love
Forward to that. Even I am in favor of yeah. This is true. This should be. But like a base level, we are missing something. Yes. Right? We are missing something. I am a diabetologist. I see so many patients, but each and every patient I cannot refer to dental. Yes, if patient something has symptoms is there, I do refer. So I do have space. So many in my clinic, I offer my dentist fellow to come and see. You give FOC consultation who do not have any disease. I give you my old patient, but FOC for all the patient who do not have anything. Consult who have some disease like periodontal disease, but nobody is ready to sit there for this close.
Actually, so what was that I want to answer. My wife is a linguist. I tell my patients to go get screened. Sometimes she will see freely also, but they're not because they don't have education about oral cavity and other things. I think our discussion should be like whether oral screening should be the mandatory for a diabetic, and because AD also screening is okay actually. Yeah. Screening is there. What is that? Not periodontal treatment or something. No, screening is very important. Yes.
you just tell them that this is the problem that you're facing. Now to get the treatment or not, it is obviously patient's call.
But screening is
The screening is important.
Right.
Yeah. See, if we have it in a list, and we need to tick all, then maybe there is a probability 80% would do. But if we do not have it in a list, maybe 10% would do.
So sixth complication is periodontal disease, diabetes mellitus. It is proven and is documented. So now start referring.
Okay, this is wrap up time now. Can we have the next last part? PPT ka set kar de, please set kar do. Start okay. Okay. ठीक है. Okay. Again, we have discussed ample, but still we would like to fall back on the policymakers. I'll quickly go back to the ADA 225 again. Dental health professionals should be included in the diabetes care team. We are not there to debate. Detection from the clinician side is important. Why? Early you detect, early you're going to be referring out. This is what we are talking about. Early we refer out, early we catch the disease, and probably we cut down the dental expenses because